Hi, good evening, everybody. I'm actually now live from Tioman. I came here for diving, but the show must go on. So I like to invite Dr. Sangeeta, my friend. We were working together in SJMC some years ago, and she has now shifted to actually Thomson Hospital, Kota Damansara. And she is actually a peds neurologist. So without further ado, Sangeeta, let's talk about your topic.
Hi, Betty. Thank you for having me here. So we'll just start with our talk, huh?
Yes.
Okay. Okay, just to double check, everything
Yes.
seen?
Good, fine.
Okay, so I'm going to talk about something which I feel is rather common in children, but maybe it's not dealt upon in detail, or maybe sometimes we say, oh, it's okay to have a headache to kids when they complain to us. But I think it's a fairly common symptom, and I would like to just take you through something common, but has a lot of diagnostic implication. So today I chose this topic called headaches in children, and my approach on these cases. Okay, so this is the focus of my lecture. First, I will talk about approach to the diagnosis and management of headaches in children. I would focus a bit more on migraine, and then I will show you how performing a focus history and neurologic examination is very important. I will go through a few slides of indication for neuroimaging, and also, very importantly, make sure we review all secondary causes of headaches. I will start by two cases which I managed. First one is a 13-year-old girl with systemic lupus erythematosus. So this girl actually was 4 months down her diagnosis, and she presented to her primary caregiver with sudden onset headache, which she described as like a hammer hitting her head. So she has baseline headache, but this is a different headache. She has a background of throbbing headache, and this has been going on for a few years. But this time the headache is worse when she lies down. The headache wakes her up from sleep. There's no recent change in behavior. There's a strong family history of migraine, and neurological examination is normal. In comparison with case 2, which is a 12-year-old American girl with 2 episodes of sudden throbbing pain over the frontal aspect of the head, which lasted 3 days in each of the episodes. It was actually better with Voltaren suppository. During the headaches, this girl preferred a quiet and dark room. She also had other symptoms, notably nausea, vomiting, and abdominal pain, especially during the episodes of the throbbing headache. The mother and aunt has been diagnosed with migraine previously, and her physical examination, like the first case, is also normal. So what do we do when we have these two cases? So this is what I think we should do. We should always approach the case step by step so that we don't miss anything. So in step 1, we want to categorize whether the headache is a primary headache or a secondary headache. In step 2, we want to categorize this headache into one of the 3 groups. So we will go through step 2, step 3, step 4 later, but we will deal more with step 1 first. Okay, so let's jump to what we're going to do. Step 1, is the headache primary or secondary? So when the patient comes to you, actually, we want to make sure we are excluding a secondary cause. We know that primary headaches are more common than secondary headaches, but secondary headaches should never be missed because the treatments are different, and we don't want to miss anything which is treatable. Remember, tension type headaches is the most common primary headaches, and migraine is the leading headache that leads people to seek treatment. So what are the type of primary headaches? Migraine, tension type headaches, trigeminal autonomic cephalgias, and either primary headache disorders. What about the secondary headaches? So these shouldn't be missed. So headaches attributed to trauma, so basically symptomatic headaches, headaches attributed to vascular disorders, either cranial or cervical, headaches attributed to non-vascular intracranial disorders, headaches attributed to substance or the withdrawal of the substance, headaches attributed to infection like encephalitis. And we definitely don't want to miss this because the treatment is very different. The children needs to be started on appropriate antibiotics or antiviral. Headaches attributed to disorders of homeostasis, like a bleeding disorder, headaches or facial pain attributed to disorders of the cranium, neck, eyes, ears, nose, sinuses, mouth, oral cavity. These are all secondary headaches. And of course, headaches attributed to psychiatric disorders. So as you can see, the primary and secondary headaches are very different, and why it's important to diagnose the secondary headaches. So as with every field of medicine, in pediatric neurology, history taking is very important. I like to speak to adolescents. I like to take their version of their history, and then I always have to retake the history from the parents again. So usually we have to do history taking twice. In the history, we want to know what's the pattern of the headache. Is it a pulsating headache? Is it a sharp pain? Is the pain like an electric shock? Or is the pain ticklish? That sort of thing. And then we also want to know whether there's a change in the pattern. For example, if previously the child had a pulsating headache, is the headache now sharp or vice versa, just to see whether there is a change in the pattern. Also take history of whether there's an aura, basically giving a clue when the headache is going to start, the onset of the headache, the type of the headache, the location of the headache, any factors which make the headaches worse or better, any accompanying symptoms, notably nausea, photophobia, and phonophobia, and also dig into the medical history to look for any comorbidities. This is important because it will guide us to influence treatment. Basically, it will guide us to choose the correct medicine to help the child's headaches or migraine. Very importantly, look at the family history with more detail, where there's any familial pattern of headache. So these are the basic headache questions. I think most of us do this in our day-to-day practice. So we ask, how and when did your headaches begin? What is the pattern of your headache? Show the diagram of the head, which I showed earlier, so that the child can choose. Don't suggest, because sometimes with children, when you tell them, is your headache like something's poking you? And they will say yes. And then if you ask them, is the headache like someone hitting your head? They will also say yes. So try to get them to describe their headaches, or even better, if they can't do that, then show the diagram so that they can choose their type of their pain independently.
I see.
Yeah, so that's the thing with children. So so then we looked at whether the headaches are daily or whether the headaches are every few days. Are the headaches gradually worsening? Whether there's a mixture of the types of the headaches, how frequent are the headaches, and is it a very sudden, explosive first headache, which is also a very significant red flag sign. Ask the child, how often does your headache occur and how long do they last? Because it's important when you classify them later into the types of headaches. It'll be good if they have a headache diary, but now most children probably, they have already a smartphone, and there are many headache apps which they can annotate when their headache started and when the headaches ended.
I see.
Ask them, ask them what makes the headache better or worse. Tell them, let them tell you. Don't ask them, okay, when you sleep, is your headache better? They will usually say yes. So try and get the answers from them and not suggest the answers. Then later ask whether there's any activities, any medication, any certain types of food aggravate the headaches. So it's important to document these if that's the case. And then also ask whether the headaches occur during any special or particular time. I think mainly for girls during their menstrual cycle, they can have something called menstrual migraine. So it's also good to see whether during their when they chart their periods, and then later when you check when their headache starts, whether it coincides. So it's a good thing to just document. Of course, look for other medical problems. In children, we hardly see this, but maybe in adults, it might be more important. And then ask whether they are taking any medication, because most of the time when they come and see me, they've already been treated with some medication. So it's important to get this history as well. A lot of the medication can also be acquired over the counter. So, they could just buy it from the pharmacy. So it's good to get this history. Next, we'll ask a few questions which may give you a clue whether the headache is worrisome. So we want to know whether there was any trauma associated with the onset of headaches. So like secondary causes of headaches, like increase in the intracranial pressure, is usually associated with trauma. And for that, the treatment is different. Ask whether the child ever had a seizure. So these are all worrisome headache questions. If the answer is yes, then definitely these children need to be seen or reviewed by a neurologist. And then ask whether there's any changes in the way the child walks, whether the child is getting a bit more clumsy, whether there's deterioration of the vision, whether the child has weakness of either hand, which is making the child choosing one hand only to walk, to write. And then whether there's any changes in the child's behavior, the way the child speaks, or whether there's any deterioration in the way the child learns. So all these are important questions. Okay. And this is a question which we always ask. And this basically, so question 12 basically gives you a clue where there can be increased intracranial pressure. So whether the headache has occurred suddenly in the middle of the night, the headache basically wakes the child up from sleep, or the headache is seen first thing upon awakening. So this is associated with increased intracranial pressure, and we must look for a space-occupying lesion. And is there any vomiting at night or in the morning? So basically suggesting increased intracranial pressure. So I think if there is yes to any of these questions, these are all patients which you have to do urgent neuroimaging. So physical examination is pretty standard. So nothing beats a detailed physical examination. Look at the blood pressure, sitting. I even do it sitting and standing, so that I look for any drop in the blood pressure when the child stands up. Look at heart rate patterns, check the fundi, look for cutaneous markers, thorough neurological exam, check the temporomandibular joints, check the sinuses, check the vision and all that. So just basic physical examination. And this is a nice acronym, which sort of like summarizes on the headache red flags in children. So they call it Snoopy, but the P has got 4 features. So so if there's any of these signs or symptoms, red flags, you need to do something about it. So the first S, any systemic signs or symptoms. So fever, weight loss, any evidence of malignancy, rash, infections, so this kind of symptoms would trigger a red flag. Any neurological signs on your examination, papillary edema, hemiparesis, diplopia, visual changes, all these are also red flag signs. Onset. So if the headache suddenly starts, the worst headache of his life, could describe a thunderclap headache. So probably the first case maybe had a thunderclap headache, but I'll share what the child had later. Look for early morning pattern awakening, and I explained this earlier. Occipital location of the headache is also a red flag sign, because usually when it's tension type headaches or migraine, it's usually more anterior in location. And then the 4 Ps, progression of an existing headache pattern, previous headache history, precipitated by Valsalva maneuver, and postural headaches. These are all the red flag signs. And of course, if a child who is younger than 3 years old has a headache, I mean, it's so difficult to even get this history, but if there's a clue from the way the child behaves, like the child is, usually 3-year-old kids, they probably just hold the head, they'll just do that, So these are all red flag signs. You need to do something about it. So don't forget Snoopy. Right. Kind of stuck, not moving. I'm just going to check so I don't miss a slide. Okay, now it's moving. Okay. So what are the 6 secondary headaches that you ever don't want to miss? So bleeds, subarachnoid hemorrhage, dissections, they usually present with posterior headaches and neck pain, sinus venous thrombosis, treated differently with anticoagulation, infection, meningitis, and encephalitis, inflammatory causes like CNS vasculitis, and conditions which causes a change in the increase in the intracranial pressure. So MAS, CSF obstruction, idiopathic intracranial hypertension, and low pressure headache. So these are the 6 secondary headache causes that we definitely don't want to miss.
Okay, since you are there at 11, can you go back to the questions that you have, number 11?
Okay.
Okay, because there is a question from Dr. David Neto asking, what is the significance of question 11?
So if there's a change in walking or balance, for example, like, okay, if somebody's got a tumor, or just say the child has a cerebellar tumor, then you will see the child walking a bit more clumsily, or, there's loss of balance. So maybe this is why you have to ask this question.
Yeah. Okay, we'll go on.
Thank you for the question. Okay, so back to neuroimaging. So, I mean, it's a very big controversy, and I realized that most of the patients who come and see me, by the time they come and see me, they usually already have decided that they want a scan for their child. Every parent, medical, non-medical, always worry that the child has a space occupying lesion. And I think the worry is very real. But the data on children with recurrent headaches who underwent routine neuroimaging found that only 2.3% had a positive intracranial pathology. So most of our MRIs actually are normal, and that's what I see in my practice too. So but we still do the scans anyway, especially because most of these children are older, and I don't really need to sedate them. And nowadays MRI is quite a safe procedure, and there are a lot of sequences which there's also like a lot of fast spin sequences, so you can really do the image. You can do the with the newer machines, you can get the images out pretty fast, so it's pretty efficient, and saves a lot of time. So I think now most parents would request for neuroimaging, and most of the time we comply, although I tend to not do it in the first time they see me unless I see any of the red flags. So these are recommendations. obtaining a neuroimaging study on a routine basis is not indicated in children with recurrent headaches and normal neurological examination. So I tend to follow these recommendations in my clinical practice. But of course, I would consider neuroimaging if there's red flags. So what we discussed earlier. So if there's focal findings, for example, if there's weakness on one side of the body, hemiplegia, and then if I examine and the child is having an abnormality of how the eyes are moving, or if the child is seeing double when I'm examining, then these are clear indications for me to get an MRI. Of course, if the child has seizures, altered consciousness, any signs of increased ICP, I think any clinician would definitely image these kids. So that's from the examination point of view, but from the history point of view, if the headache is very recent onset, they don't really classify what is recent, but I would say, within 1 or 2 weeks, and very severe, like case 1, the worst headache in her life. I think this is also an important indication to scan. And if there's a change in the way the headache is behaving, scan these kids. And then if there's any systemic signs or symptoms, please scan these kids. So variables that predicted the presence of a space occupying lesion, this I think on an old paper, but this is one of the few papers which I could find to basically help us to decide, at least in a more scientific basis, who do we image. So if the headache is short duration, so 1 month, but most of our patients will present, within 2 weeks. Absence of family history, abnormal neurological findings, abnormalities in the way the child walks, and whether there are seizures. So let's go back to the first case, okay, before we do step 2. So we're still in first case, step-by-step approach, which is deciding whether it's a primary or secondary headache. Okay, so remember the first case, the girl with SLE. Remember, she has SLE, it's a systemic disorder. She has a sudden onset headache. So she's a background throbbing headache, and now she has a sudden onset headache. So there's a change in the way the headache is behaving, right? There's a change in the way the headache's pattern. And she said it's like a hammer hitting the head. So maybe something explosive, maybe, but this is how she describes. So this, even from the history, we would definitely image this kid. And even from the history, you see the headache is worse when she lies down, wakes up from sleep. So some clue there that suggests there might be increased intracranial pressure. The strong family is trauma again, but this didn't stop us from doing that MRI. And that's an MRI. Okay, so this is the left. So this we are seeing it in a coronal section. So that's the left cerebral hemisphere and that's the right cerebral hemisphere. And what's abnormal is all this, and that's the cerebellum, okay? And what you see is all these white sort of signal abnormalities. You can see it on both cerebral hemisphere and also the cerebellum. And what you notice here is there's a huge thrombus in the sinuses. Okay, so this child in the ward as she got admitted within few hours had 2 seizures. I imaged her after her first seizure, and this is what we found. So her SLE basically put her at risk of having sinus venous thrombosis. So she basically had a venous stroke, and that's her MRI findings.
So this is a question from a doctor from Dokwiti, Dr. Hui Chi Chia. So she asked, how is the presentation of sinus venous thrombosis differ? How does it differ from primary headache? But before you answer that, can I ask you, is primary migraine primary headache?
Yeah.
Oh, so primary headache is basically migraine.
Correct.
Oh, I see. So, okay, primary headache is, okay.
So all the secondary headaches are the symptomatic fellas. So the infections, the CSVTs, the traumas.
So you can only differentiate the sinus venous thrombosis from the primary headache from imaging?
So that's the way we are going to definitely diagnose it. But from the history, there are already some red flags that these are primary headaches. So I'll go back to the way this girl presented. So if you look at the red flags earlier, okay, maybe we go back. Hold on.
Okay, I can tell the red flag is, of course, she has an underlying premorbid status, basically.
Perfect.
Because she has SLE, and we will not take anyone with SLE with sudden onset of any symptoms, especially headache, lightly. True?
Perfect. Because actually, when I after we treated her sinus venous thrombosis and of course, her headache went away, right? The sudden onset that went away, she still had background headaches, the throbbing headaches. And so this girl actually has a background migraine.
I see.
So she has background migraine, and I followed her up for a few years. So she was on topiramate for the migraine. So it was a bit complicated, because when she first presented to me, I'm like, is this migraine or what's this, So then, of course, kept a close eye on her like a hawk. So basically, she has background migraine, and also the venous sinus thrombosis, which caused her to have a venous stroke. So so she was quite a challenging case, but she did very well. So the background throbbing headache was there for, I think, about 2 years. So that was about 11 years old, like that. So that's an MRI.
Yeah.
So we were quite shocked to see the changes, quite diffuse changes. But, she, NCSVT, venous sinus thrombosis, is quite well described in SLE. So it's a diagnosis which we shouldn't miss.
Yes.
So from the clues from the history, there's some clues that we shouldn't miss this.
Okay, if a child doesn't have SLE, is there a likelihood of getting a venous thrombosis?
Yes, I've seen a venous thrombosis in children, usually in the setting of dehydration.
Oh, I see.
Dehydration, and then I've seen in kids with coagulation disorders.
Okay.
Where they are sort of more pro-thrombotic sort of states.
So have to take them seriously,
Correct.
I mean, it's unlikely a child will complain of headache, to be honest.
True. I just chose this case because I thought it was a nice case to illustrate a background SLE and a girl with a background migraine on top of it, a different headache, and
the MRI. I mean, even for me who don't know I don't know how to read MRI, I can tell significantly that there is something wrong with it.
Correct. So I thought this is a very nice case to share.
Right, thanks. Okay, we go on.
Okay, and now let's go to the case 2, which we spoke about. So 2 kids, right? So this is a 12-year-old girl. Remember, 2 episodes of sudden throbbing headache over the frontal aspect of the head, 3 days, better with Voltaren, which is an anti-inflammatory medication. And during the headache, she has nausea, vomiting, abdominal pain. She prefers quiet, dark rooms. There's a family history of headache. Her physical examination was normal and her MRI was normal. So what do we do with her? Okay, so this is how I would move on to my step 2. So remember, we spoke a lot on step 1, which is to not miss the secondary causes, remember? Okay, now we will go to step 2. Okay, so like for this girl, so we will divide into the headache syndrome. So whether it's a short duration of headache, whether there's a recurrent long duration of headache, or chronic daily headache. So for this girl, we would call her, recurrent long duration. Of course, she just started her headache symptom, but these are the guidelines for classifying them. And why this duration is important, I will show you in the next slide. So remember, short duration is less than 4 hours. but it's usually just one off, right? Recurrent long duration is more than 4 hours, but it occurs in less than half of the days of the month. Chronic daily headache, more than half of the month, more than 15 days a month. Okay. Why this is important is because it basically classifies them into probable diagnosis. Okay, this is what I mean. Okay, so if the child has short duration of headache, the diagnosis can be tension type headaches, migraine, trigeminal autonomic cephalgia, which is quite rare in children, which number 1 and 2 are more common. Of course, if it's also recurrent long duration, it can also be tension type headaches, migraine headaches, primary hypnic headaches, a headache which I've not seen in my practice. And of course, if it's a chronic daily headache, then we would basically diagnose them to have either a chronic migraine disorder, chronic cluster headache, chronic tension type headache. So basically, stratifying them into the 3 different duration may give you a clue on what is the diagnosis. But remember, tension type headache is most common, but they routinely don't come to seek medical attention. But migrainous headaches are the headaches which make this family seek medical attention. We will go through on how to diagnose at least migrainous headaches in this talk. Okay, let me just move on to the next slide. For some reason, I don't know why my
Just get stuck, is it?
yeah, it's getting stuck. I'm not sure why. I tried it on just now. It was fine.
Yeah.
I don't know why.
Okay, so while you will get this thing going, Dr. Ambika Devi from Docquity asked, what was your treatment for the sinus venous headache?
So we treated the sinus venous thrombosis. We anticoagulated the child with heparin, and then after put the child on Clexane for 3 months.
Oh, you don't use the newer generation of anticoagulant? Or
No, for pediatrics, we generally a bit more we basically still use heparin and Clexane. What do you all use?
I have not actually treat, because this is not part of cardiology, but we don't use heparin anymore at all. So I haven't
still use
heparin for almost 20 over years already.
We
Why
still
did
use in
heparin?
pediatrics.
Why don't you just start with the Clexane?
So because heparin, we can achieve because it also depends, because this child was in ICU, the child had a lot of seizures, and involvement was quite bad, quite vast. So after discussing with the rheumatologist, I think the consensus was to very quickly anticoagulate with heparin first and then convert to Clexane, I think after a few days. Of course, it's messy with heparin, but generally, most of my patients, we generally anticoagulate with heparin first.
And then when do you convert to Clexane?
I think for this child, we did it, I want to say after, I think 5 days, I think. Yeah.
And this Clexane, your dose is weight dependent?
Correct.
Okay. And 3 months. So 3 months, and is her SLE in remission, or is it control?
It's in remission.
Okay, good. So heartbreaking to have children that are sick.
It's very heartbreaking. It's very stressful also, because one part you're dealing with the parents, and then one part there's a sick child. So
that's why
pediatrics is quite stressful sometimes.
Yeah, I don't like this. Okay, we go on.
Okay, so I'll speak a bit on, so remember we had all those classifications, but I just want to speak a bit more on migraine in children. So migraine is a type of headache. So sometimes we say migrainous headaches. Okay, it's actually quite common in children. I've seen, I think, as young as 6, 7 years old.
Oh my God.
Yeah, because you have to understand nowadays the kids, they're very, very clever and they can really describe their pain very well. You know, sometimes they speak to you and you listen to them, you're like, oh my God, wow, how did the child actually do that? So, you know, you get younger children describing their headaches really well. So I think that helps clinicians like us diagnose this condition. Okay. Of course, it's more common through adolescents, but I've seen different types of migraine presenting, you know, as young as 6. So the prevalence actually increases as these children grow older. So the prevalence quoted is about 3% among, I don't know how a 3-year-old would be able to diagnose as migraine, but this is what it's quoted in the papers. 3% from age 3 to 7 years, and you know, it goes up to 25% between the ages of 11 to 15 years old. Boys tend to have onset of migraine earlier compared to girls. Yeah.
Okay.
Sorry,
Okay. So another question is, Dr. Chia Carling asked, may I ask regarding the recommendation of obtaining neuroimaging? It's not indicated in children recurrent headache, but with normal neurological examination. It's from which guideline?
that one is from, I think, did I quote the paper?
Okay.
I think it's from either the International Headache Society or CAFLGIA, one of those recommendations.
Okay. Because you can't be scanning everybody, right?
No, you can't. But to be
Specify-
fair, you know, like in areas which practice more defensive medicine,
Yeah.
I think certain countries, they, you know, they practice more defensive medicine. I think they tend to image even on first headaches.
Yeah, and it's quite difficult to pacify parents these days that nothing needs to be done, right?
Correct. So that's why I said sometimes they come expecting it to be done. And you know, a lot of parents are also professionals, medical doctors, you know, consultants, and they really think of complicated diagnosis. And there's always a worry whether the headache is a brain tumor. So sometimes even on the first consultation, doctor, I want an MRI because I just want to have peace of mind that my child doesn't have a brain tumor.
Do you do CT scans on kids?
We can do it, but generally I don't routinely do it because the risk of radiation, and we know that, you know, if you do maybe just one CT scan won't harm so much, but you know, if you do more CT scans, it puts the kids later for hematological malignancies. So I generally don't do CT scans unless in the setting of trauma.
Okay.
Mm.
Okay.
So incidence of migraine, about 5% of children actually suffer from migraine, gender ratio 1:1. Younger, more in boys. So we said earlier, in older, more in girls. Okay. Okay. So this is the diagnostic criteria for migraine. So IHS is International Headache Society. So there's such a society, So there's actually if you look at the criteria, there's a lot of criteria for all the different types of headaches. So, but I won't be going through everything in the interest of time. And, you know, we just want to focus on a few things. At least we go back with something which we can remember. So I chose to just discuss on the diagnostic criteria of pediatric migraine without aura. So 30% of children will have aura, but at least the most commonest migraine presentation, pediatric migraine without aura. So that's why I chose this diagnostic criteria to discuss. So in the diagnostic criteria, it's quite clear, very, very nicely delineated. So more than 5 attacks and fulfilling features B to D, which are headache that last 1 to 72 hours, headaches that have at least 2 of the 4 features. So frontotemporal location, either bilateral or unilateral. Commonly children, I think like adults also, tend to complain of unilateral pain. Sometimes they even complain of unilateral eye pain. But basically it's the frontal, and then they just sort of like getting referred pain to the eye. So I would still classify that as a frontal location. Pulsating quality, so pulsating, throbbing, whichever words they use. So that's the way the character of the headaches are in pediatric migraine. Moderate to severe intensity, you can use a pain score to probably gauge this, and then aggravated by routine physical activities. So this is from the classification. And D is also important because most of the patients which are eventually diagnosed as migraine do have nausea and or vomiting, and photophobia or phonophobia. In brackets it says maybe inferred from their behavior, because some children just, when they're young, they just go into the room, they off the lights, and sometimes they know how to switch the aircon, and they just don't want any noise, and they just lock themselves in the room and sleep. So you can infer that there could be photophobia or phonophobia. Sometimes the patient has maybe not 5 attacks, like the second case, the child only had 2 attacks, but the history is very suggestive of migraine, and they always say medicine is imperfect science. It's not a perfect science. So do we still diagnose this patient as migraine? Of course, if we follow the criteria, no, because you need to have more attacks. Duration, yes, the child ticked the box, right? I think the headaches were about 2 to 3 days. And then she had those features C and the features D, but she didn't have enough attacks. So then I will explain to the mom, we can't really call it migraine yet, but we have few features. So then we may not want to start the child on pharmacotherapy yet. We would use non-pharmacotherapy methods to try and mitigate the migraine. So this is just how I do things in my day-to-day practice lah. So any questions on this before we move on?
Non-medical treatment for this?
Yeah. So I usually look back into their diet, their sleeping habit, the screen time, whether they have regular meals, because I noticed that children who skip meals tend to have it can trigger their headaches.
I see. Okay.
Yeah. So like when you're hungry, then you become angry and get bad headaches. So if you have migraine, then you tend to it can worsen your headaches. Another interesting I learned during my practice is I always tell my patients to have a good high protein breakfast in the morning. And I noticed, because I'm a migrainer myself, so I also use a lot of these tips in my day-to-day life. So I always tell my patients that have a good high protein breakfast, so that basically prevents and regular meals to prevent hypos, or prevent lability in glucose. So glucose lability can trigger headaches. So so these are the things which you try and tweak before starting medications, because even if you start medications and you don't do any lifestyle changes, then it doesn't make sense to start medications.
I see.
So drink a lot of water. They need to drink lots of fluids. And now, sometimes it's really hot. They're saying there's this heat wave, a lot of children with heat stroke. You will see more migraines in hot weather. So, prescribe lots of fluids. Don't want carbonated drinks. Sometimes it can worsen headaches.
What is the pathology behind migraine?
So, there's a lot of the exact pathology is essentially unclear. Some people think it's vascular. Some people think it's inflammatory. I believe there's probably a combination of both because, the pulsatility, the way that behaves, it tells you it's a bit more vascular. And then the part that when you give anti-inflammatory agents, the headache becomes better, that tells you there might be an inflammatory component. So I think there's a component of both. And of course, there is also genetic preponderance. Migraines tend to come in families. So there's also this genetic basis which can also explain it. But in certain pediatric migraine syndromes, like the familial hemiplegic migraine, that's associated with genetic mutations. But I'm not going to go to that. It's too hardcore. We just want to look at something which is more, something nice and which all of us can relate to. I'm sure all of us have had headaches and we're wondering whether it's a migraine. So something a bit more, something we touch base with most of us. So I chose this.
Okay.
Okay. So let me see my next slide. Okay. So what are the strong predictors in migraine? So from this paper, it's an old paper, but it's nice because, it's easy to remember this word. So PIN. So this paper says, look for these three things: photophobia, any impairment, basically during the headaches where the child can continue to do what the child or adult is doing. So if somebody has got severe migraine, you can't continue to study or do your work, you will definitely stop it because it really affects your day-to-day work or activity, and whether there's nausea. So in this study, it's an old study, but it's very nice because, very difficult to get studies like this. So if you have all 3 yes, then 98% positive predictive value, this can be migraine. So it's important to take all this history when you're speaking to the family or the child. So just now I spoke about the migraine classification. So ICHD stands for International Classification of Headache Disorders. I forgot it, but I just checked it before the talk because sometimes you can't remember all this this short
I can imagine.
So yeah, just a small thing which I had to do and remind myself. So as you can see, so many types of migraine. So interestingly, I've seen all these types. So if I was speaking about this type, Betty, remember you were asking about pathophysiology. So this, the hemiplegics.
So they recover completely from the hemiplegia.
Yeah. So when they have their headaches, they are hemiplegic, they are weak. So these are usually
basically
related
that must be vascular, right?
Correct. So it's actually channelopathy.
Oh,
It's usually calcium channels.
I see. Okay, that's very interesting because we also have channelopathy and they usually have sudden death cardiology.
Correct. So sometimes if you take the history, you can get history of sudden cardiac death.
Oh.
Yeah, because I'm not sure for the you're talking about like the Brugada and the,
Yeah, that's right. That's right. Long QT.
That's which channel? What are the genetic?
I cannot. I think they are sodium channel for long QT.
Okay.
Brugada, I'm not really sure.
So for these are mainly the calcium channels.
Okay. Yes.
Yeah. So if a child has got hemiplegic migraine, then of course the pathophysiology would be a channelopathy, and usually we do genetic testing and diagnose these conditions lah.
Okay, let me just.
But retinal migraine is probably vascular. Basilar migraine is probably vascular. I think the other migraine with or without aura, probably more inflammatory. So I think I feel that there's a mix, but to be really honest with you, nobody knows what's the exact pathophysiology. So this is the way we classify it. So maybe for child number 2, we would probably call her probable migraine without aura. That will be her diagnosis.
Oh, in Brugada, it can be sodium, potassium, or calcium. Okay.
Okay, interesting. So another interesting thing I see, you see 1.6, okay, the episodic syndromes that may be associated with migraines. So I see a lot of children, when I take the history, they actually present with recurrent abdominal pain, cyclical vomiting in early years, and then later get headaches. And we think these two might be related also. And sometimes even when they have the headache, they have the abdominal pain. So I also see a lot of children having this kind of like combination of symptoms.
Can I ask you, what are the common auras?
Most of my patients actually can't, in our patients, okay, so our Asian patients tend to not be very descriptive, but among the more descriptive ones, usually is visual.
Like they see a hallucination, or is
No,
it?
so they will see a combination of things. So some of them have said they have seen black and white checkered boards. Some have said they've seen rainbow colored rainbow colors. Is it colors? Some have seen flashes of light. Some
Oh,
have seen circles, like sort of like circular objects sort of like moving. Sometimes the circular objects are associated with central scotoma. Some is just the circular objects like moving from left to right. A bit like a moving sort of thing, not static. So the auras can be either static or dynamic, like like on the like something which is it's moving. I've not heard of a lot of children complaining of tinnitus or anything as their aura, but most of them are mainly visual.
no. Okay, we go on.
Okay. Okay. So step 4 would be to formulate a specific treatment plan. So as we spoke about the non-pharmacological approaches, now I spoke about what we do, like the diet, the screen time, the sleep, the fluids, and all that. During taking this history, we want to look for triggers. So if there's trigger, identify the trigger, manage the trigger, get the child to diary the headaches, and then teach the child on how to manage the headaches. Okay. Sometimes I also prescribe the child on multivitamins. Vitamin B apparently has some small data which says it can also help migraines, and also magnesium and coenzyme Q. So in some parents, even at the beginning, I start them on some of these vitamins, even from the beginning. And any questions on this?
Oh, quite a lot actually. So
Yeah, go ahead.
we have answered some questions along the way. And Dr. Ambika asked, what is the prognosis after treatment for the sinus venous headache?
It was very good. The kid did very well.
Good. I'm so happy.
Because we diagnosed fast, we treated, the child's fine.
Okay.
I already discharged from my follow-up already. I let the SLE people continue the management of the SLE.
So, Dr. Key asked, what type of migraine syrup do you usually use for PITS patients?
Yeah, I will go through the pharmacological approach in my next slide, but maybe since the question has come up.
Okay, we go on.
Yeah, so let's go on. So we spoke about the lifestyle modification. Let's go to the treatment. Okay, so very busy slides. This is something from papers. So basically what I use is either the triptans. Sumatriptans are safe for children. I use pizotifen. I use flunarizine. Beta blockers, not so much. I use topiramate a lot, and amitriptyline. These are the ones I use.
And then NSAIDs, do you use NSAIDs?
Yes, a lot of NSAIDs. I use a lot of ibuprofen mainly because it's a bit more gentle to the intestine, to the gut. And then in bigger children, I use celecoxib.
Okay. So,
I don't use lots of ergotamine. I don't use ergotamine because there's a risk of getting like what do you call the malignant, it can turn into a stroke. We call it the malignant sort of transformation of a headache and get like stroke. So I'm a bit more careful with ergotamines. I'm not so comfortable. Antiemetics I use if they're admitted and in they have a lot of vomiting, you need to give an antiemetic. If not, means it really doesn't work.
okay.
So why we need to treat these headaches? So I always tell the families, don't be scared of starting first line treatment. So first line treatment, unless you ask them to take other, a lot of them have, by the time they come and see me, have already tried paracetamol. I believe paracetamol doesn't really work so well in the real migraine, because if the pathophysiology is inflammatory, we want to give NSAIDs. But some patients say it works. So if by history it works, then I give the paracetamol. And I always tell parents, don't wait and don't be scared of the medicine. No, don't be scared and think that, oh, my kid's going to be an addict by taking paracetamol. Treat the headache and nip it at the bud. That treat it quite early, because you will see that if you don't address the headache early, it tends to get more chronic and more prolonged, and then it's a bigger headache for the doctors treating them to get the headache, sort of sorted.
Okay, I've never had migraine, and I almost never have headaches. So is it very debilitating?
Yes.
So does it
Because
affect their self-esteem? Do you think it will affect their self-esteem, confidence?
I think if it's really chronic, then yes, maybe it will affect the self-esteem. But I think most of it basically affects their school performance.
I see.
Because they can't go to school. And then, I mean, I guess if they don't go to school, they don't learn, maybe that sort of like affects the self-esteem.
Yes, and it increases the stress and yeah, it's quite pitiful. Yeah, I never thought that it's a child would get migraine.
Yeah, they can. So they tend to miss school. The ones we know, like you can see before treatment, after treatment, they'll be like so terrible. They won't be going to school. Then they will lag in their studies. So when they go back, they feel they've missed out more. So it does have a negative impact on their school, and they can't really play games so much because if it's hot, it triggers their headache. So they tend to be a bit more introvert, stay in the house. So it does affect.
Okay.
So I think we want to take home this message that we need to treat with NSAIDs the early headaches. We want to treat it. We don't.
Yeah, it's important for the GPs because they are probably the first liners, and it's quite. I mean, it's always a thing for doctors to think, oh, should I start a child on medication?
Correct.
So you need that confidence to say, okay, I think I should start the child on confidence. Okay, we have to quickly wrap it up because we have a lot of questions.
Oh no, sorry. Okay, so I'll just quickly wrap it up. Maybe I answer the questions and then they're better. So basically, acute treatment, I use correct dose formulation. That's the maximum doses, 2 to 3 times a week. Avoid medication which causes overuse headaches because it can get rebound headache, and selection of medication based on disabilities. But just for the GPs out there, I mean, you can always try paracetamol first as first line. It's not wrong. Even when I did attachment with headache specialists, we also say you can try paracetamol, although we think it doesn't work. So PCM first and then Brufen. And then if they need preventative medication, usually they'll already be seen by neurologists. So if the headaches are quite severe, frequent, when the acute abortive medications are ineffective, I usually set them on preventers. And if the headaches are, causing a lot of issues and challenges with school and activities, I generally start them on preventers. Okay, I think this is my last slide. So remember, Betty, migraine can happen in children.
Yeah.
It happens, and I think it's pretty common. Like it's one of the common consults I get in my clinic. Migraine is often unrecognized because we assume that it's okay to have a headache, and if they don't have it often enough, we don't diagnose the migraine. And remember, children can fail to communicate their symptoms. So, looking at the behavior and seeing what they do are ways to try and diagnose this condition. Impact can be quite debilitating, disabling. So treat the pain, get the pain down. Let's have a happy kid.
Yes.
Effective treatment is available. We have been quite lucky. Most of our patients have been quite well and with appropriate treatment and also lifestyle modification. We're just not going to treat without lifestyle modification.
Okay.
So,
We have a question, and that question is from Dr. Nuzemi, and it's about her daughter. Oh, I'm so sorry. So my daughter was diagnosed with medulloblastoma when she was 6 years old in 2020. I'm so sorry. Initially thought it was migraine until she lost her balance while walking, and straight away when, I hope I'm so sorry to hear that. It really breaks my heart. Okay, can you see the chat box, and then can you continue with it? Because in the meantime, I will try to I want to share the QR code for the doctors to get the CPD points. Can you see it?
Okay, I think she just said, initially thought it was migraine until she loses her balance while walking, then straight away sent for MRI. Thanks heaps. But see, what she said was, there was, so there were already red flag signs, right? See, so there was losing the balance. So hence yeah.
But I think it's fair to think that it's migraine first, right?
I think it's fair, but you shouldn't lose balance.
Oh no, when once she lose balance already, she was already sent for MRI. Okay, the next question. Go on with the next question, please.
Okay.
I'm still trying to share this thing.
Question 5 from, hold on, it's moving.
Okay, can you see
Chop.
my screen? Okay, this is a QR code. Now, this QR code are for doctors, and they are for doctors in Malaysia to get the CPD points. So you can actually use your MMA app to scan this. So you can also scan this. And with that, we go on to the next question, which said, Lily Sufida Abdurrahman asks, can headaches due to pediatric migraine resolve on its own, or will it persist till adulthood?
Well, that's a good question. I need to speak to my adult neurologist because, so we see them in the pediatric age group, and generally most of my patients don't tend to be chronic. Like I don't see them for years, of having headaches, like my patients with seizures. So usually I manage to sort of settle the headaches when they are younger. Yeah, I rarely see it becoming very chronic.
And you yourself had headaches since how old?
Actually, very interestingly, my headaches I think I probably had baseline headaches, but when I was in Canada during my neurology training, because there was a change in altitude. So change in altitude is known to cause headaches. So there was this, so either change in altitude, change in
yes.
So you can get vertigo, you can get headache. So I had a posterior circulation headache. I thought I was turning blind. I had aura, and then I was seeing circles moving, and then
I see.
I was so scared, and there was a severe headache, and then I just went to the ER, and suddenly I had tinnitus, and then the migraine specialist came, and but that was the most scariest headache I ever got in my life. But generally after that is more of the tropic one. But the worst was when I was in the northern hemisphere of the world where the weather is bad.
I can't imagine. Okay, Dr. Hui Chi asks how to differentiate aura from retinal detachment. I think if it comes after an aura, and after that you have a headache, I think.
Retinal detachment, wah, susah lah.
I passed this on this first lah.
Difficult question to answer lah.
Yeah. Vijaya Lakshmi Dr. Vijaya Lashmi asked, when do you start pharmacotherapy for your children? And you have mentioned as early as possible, right? And then
Yeah.
you start
I try non-pharmacotherapy first, and
Yeah.
then, if it fulfills the criteria of pharmacotherapy, then I will start them. So recurrent headaches, severe headaches, child not going to school.
And then you put them all together, or for example, once the headache comes, you give them NSAID or Panadol.
Okay, so I give them a plan.
Oh,
So they
I
have
see.
headaches.
Okay.
They have headaches to take. So they know when to take which medicine. So they have like a headache chart. So they know what is 0, 1, 2, 3, 4 until 10. So
Uh-huh.
just say I will usually tell them to take their acute treatment when the headache score is about 4, 5, like that. So when the headache score is about 1 or 2, I tell them to either put an ice pack, put a lavender, put a migraine stick, drink lots. Sometimes even drinking lots of water during the acute attack can help. So I tell them to do that when the headache score is about 1, 2. And then if they see it building up to 3, 4, I tell them to take ibuprofen lah. So this is the acute abortive part.
You start them on preventive measures then.
Correct. Then, so some of these kids are not on preventers. Some of them are already on preventers. So even if they're on the preventers, they can still have a migraine breakthrough. They can still have a migraine in between. So I still use this thing in my clinical practice. 1, 2, they can take a roll-on in school, and then when it becomes 4, then pop in a ibuprofen, whether they are not a preventer or whether they are on a preventer. It doesn't matter. But you always must treat the breakthroughs.
Okay. So Dr. Chia asked again, how do you titrate the triptans and preventers medication dose?
Okay, so I'm not a fan of triptan. So I like to use ibuprofen. I like to use the inflammatory medications more.
Okay.
But generally we have, I think, in Malaysia, we don't have as many preparations as overseas. I think our 1 tablet, if I'm not mistaken, is about 25 mg. So generally, if it's like a 7-year-old, 8-year-old, I just give them like 12.5, like that. Yeah. But I think overseas, they have different formulations, other countries, but we just use what we have in our country. So generally, that's why I prefer to use the inflammatory agents. I find that more helpful.
Okay. Dr. Lily Sufida asked, how do you differentiate symptoms of dizziness instead of headache in children during his taking?
Okay, interestingly, most of children with headache actually complain of dizziness. The
Oh.
dizziness actually their headache. So children, they will say saya pening. Then I'll say, apa itu pening? I'll ask them, apa maksud you pening? Then they'll say, oh sakit kepala. Or sometimes they say pening tak maksud pening. Then actually their pening is lightheadedness. So this word dizziness is actually a misnomer. So sometimes the dizziness is the sakit kepala. You know what I mean? So we must get the history correctly lah. Sometimes when you have headaches, you can also have vertiginous, like if you have posterior circulation headaches, you can be a bit lightheaded, like vertigo, like that. So that also can accompany the frontal throbbing headache.
Okay. So I think that's quite an amazing talk. I really enjoyed it. And we really have a lot of questions, and it was very interactive. So maybe we can bring you back to give another talk next time.
Yeah.
Very nice. Okay, so I'll stop share now.
Pleasure.
And we catch up another time. Thank
We'll
you.
catch up for coffee soon, Betty.
We'll catch up on Facebook.
Okay. Bye.
Guys, bye.
Thank you, everybody. Bye.
Yeah, bye. Thank you, guys.
I left my number there and email if there's any questions. Please
yes,
feel free to email. Yeah.
Yeah, you can email, or maybe you can also share your slide in PDF form so that we can share it.
I'll email to you lah.
You send to me on WhatsApp also can?
Can. Thank you.
Bye, guys.
Bye.
Okay, bye, everybody. Next week, we have another talk. I can't remember what it is these days. Okay, but next week is our last talk for May, and after which we won't, because I'm going to Paris and UK for 2 weeks. for meeting and to see my kids. So we'll come back in June after that. See you guys. Bye. Bye,
Bye.
Sangeeta. Thank you
Bye,
so
see
much.
you. Bye.
Bye. Still got 31 people waiting. Bye.
Bye.
Okay, thanks, guys.
All right, we're off live. Thank you, Dr. Betty.
Okay. So
Thank you, Dr.
cannot scan means that maybe